Good afternoon, everyone. Welcome back. We are going to get started in a moment, so I'll ask NCHS staff to come on up as opposed to come on down. Okay, so we're going to go ahead and get started, and the next presentation will be on asthma control, and Cheryl Bullock will lead us in that presentation and invite the presenter to come up as well.
Hi again. Our next topic, as mentioned by Ms. Pickett, was that we're going to deal with asthma control. And we have Dr. Elizabeth Masui, from Professor of Pediatrics, Epidemiology, and Environmental Health Sciences from Johns Hopkins University. She will present our clinical piece of the presentation.
Thank you. It's terrific to have the opportunity to present about asthma control and implications for ICD-10 codes. So a little bit about asthma epidemiology. So asthma affects about 18.7 million adults in the U.S. and 6.8 million children. So that's 8% of adults and 9.3% of children. And it's a clinical diagnosis. And so asthma is characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. And because there's a certain clinical picture, there's no single test to diagnose it. The diagnosis is based on someone having a clinical picture consistent with these features. So if a patient has symptoms of recurrent episodes of airflow obstruction or airway hyperresponsiveness, and the airflow obstruction is at least partially reversible, and that can be demonstrated by responsiveness to albuterol or rescue medication, and alternative diagnoses are excluded, then the diagnosis of asthma can be made. So there are two distinct clinical features of asthma that were delineated in the most recent expert panel report for asthma guidelines. And so one clinical feature is asthma severity and the other is asthma control. And the current codes reflect or capture asthma severity, but they do not capture asthma control. So severity is the intrinsic intensity of the disease. It's often reflected by the amount of medication required to maintain control. And there are several categories that include mild, moderate, and severe persistent disease. And this is a feature that informs certain types of risks a patient may have. So risks of medication side effects because they're requiring, for example, high doses of inhaled corticosteroids, or their risk of having long-term sequelae of their asthma, such as progressive lung function decline. Control, in contrast, is the degree to which the manifestations of asthma are minimized. And these manifestations include the frequency and intensity of symptoms, functional limitation, having a recent exacerbation, and then also their current lung function. And these categories in the guidelines are well controlled, not well controlled, and very poorly controlled. And this feature, in contrast to asthma severity, is what is used at all the follow-up visits to gauge responsiveness to therapy and to guide therapeutic decisions. So in practice, I want to illustrate the difference between severity and control with two hypothetical patients. So patient one here is on high-dose inhaled corticosteroids plus a long-acting beta agonist. So they are on the highest amount of controller medication. In terms of their manifestations of asthma, they are needing their albuterol or their rescue medication and having symptoms about once a week. They're not waking at night with asthma symptoms. They have normal lung function. They haven't had any recent exacerbations, and they have no functional limitation. So their asthma severity category is severe persistent, but because they have little to no manifestations of asthma, they are considered well controlled. Patient 2, on the other hand, is on low-dose inhaled corticosteroids, so a minimal dose of controller or daily medication, but has many manifestations of asthma. So this patient is using their rescue medication or having symptoms 4 times a week, They're waking up at night twice a month with asthma symptoms. They have abnormal lung function. They've had a recent exacerbation, and they have some functional limitation. So their asthma severity may be more in the range of mild persistent or so, but they are not well controlled because they continue to have manifestations of their disease. And when these patients are evaluated at a follow-up visit, what to do with the medication is primarily based on their asthma control. So patient 1, you may leave on their controller medication or consider bumping it down depending on how long they've been this stable for, but patient 2 clearly needs to step up on their asthma medications. So the goal of therapy, as I mentioned, is to control asthma, and the specific goals are aimed at having no symptoms or rescue medication use that more than twice a week. So you want to keep those under 2 times a week on average, not waking up at night more than once a month, having the asthma not interfere with any activities such as missing school or work or athletic activities, having normal lung function and keeping exacerbations to 0 to at the most 1 per year. And again, as I said, control is assessed at each visit and medication is titrated accordingly. So I will quickly just mention the proposed codes, but Cheryl will really give the formal presentation about the coding. But the general proposal on behalf of the Quad AI, which is an allergy professional organization, is to include the concept of control in the codes. And you can see the addition of controlled here under mild intermittent asthma. You can see the addition of controlled under mild persistent asthma. So this adds a control element to the severity coding that is already present, and the same for those. So with that, I will hand over the podium to Cheryl. Thank you.
Sure.
Nellie Leon, she's saying, how would you differentiate an acute exacerbation from uncontrolled? In the sense that up to this point, acute exacerbation has been interpreted to mean that someone could have been under medication and then they had an acute flare-up. And sometimes that would mean that they would show up in the emergency department and so on. So how would I be able to tell the difference, or a physician tell the difference between uncontrolled and acute exacerbation?
So usually uncontrolled is something that happens over a more chronic time period. So that might happen over a period of a couple of weeks or more. And exacerbation, typically they are very well controlled. Oftentimes there's a trigger that's cited, such as a viral infection, and they have pretty significant and severe symptoms that oftentimes require a burst of oral corticosteroids. So this is not something that typically responds to an increase in the baseline controller medication. So it's the severity and the abruptness of onset that distinguish an exacerbation from someone who's just having less well-controlled asthma.
Thank you.
Mm-hmm. Other questions? No.
Okay, for the code modification proposals, it is found on page 18 in your package, and this is slide number 10. Okay, as previously mentioned, for code category J45, asthma, the revisions are including a revised code for each of the mild intermittent asthma, mild persistent asthma, moderate persistent asthma, severe persistent asthma, and other and unspecified asthma. For each of those code categories, we're revising the codes. For example, J45.20, mild intermittent asthma, we're revising uncomplicated and put controlled. And there's a proposed new code for J45.23, mild intermittent asthma uncontrolled. And this is found throughout the entire code category. Again, an example, J45.3, mild persistent asthma. We're revising the code J45.30, mild persistent asthma, revising uncomplicated and putting controlled. And the new code J45.33, mild persistent asthma uncontrolled. J45.4, moderate persistent asthma. J45.40 is uncomplicated again to controlled, and J45.43, moderate persistent asthma uncontrolled. So again, this is inconsistent with the modification request that has been submitted. Questions and comments?
Jean Yoder, contractor for the Defense Health Agency. As a data analyst, we have a little bit of a problem whenever you change an existing code. And the thing is, we will already have 1 year's worth of data with J4550 as being the uncomplicated. And so it's hard for us to be able to flag and alert all of our analysts that the code changed its definition. And so, as opposed to changing that, if it's like this, it's better with data analysis when we're doing a multi-year analysis to simply delete that code and then start 2 new ones, because uncomplicated doesn't necessarily mean controlled. And so we'll have 1 year that you won't know just by looking at the codes that it's a different code. Okay? So it's just a suggestion. If you have enough space.
Okay,
Okay.
thank you.
Sue Bowman-Ahima, I'm just going to comment. I don't know how well this is all documented and understood by the majority of physicians, but I have long-term bad memories and PTSD from diabetes. And
Controlled versus uncontrolled.
and the many years that we had questions of, is this controlled? Should be this coded uncontrolled? And I even had doctors calling me, telling me, should this be coded as uncontrolled or not? The doctor didn't even know. So I know that maybe Nellie's staff is worried about running out of coding questions after ICD-10 is implemented. And this is a new version of diabetes that's going to result in job security for her staff for many years to come. But I would just like to point that out for consideration, and maybe it's not the same thing, but as soon as I hear controlled or uncontrolled, I start having heart palpitations.
Okay. And could you even give us maybe any additional information that would be helpful as we try to differentiate uncomplicated versus controlled, the differences?
So I think there are 2 different questions here. One is a concern that this seems like maybe similar to controlled or uncontrolled diabetes. Yes, this is sort of the absolute bread and butter of assessing asthma at every single visit, and this is the language that's used by any physician that assesses asthma. So it's I realize that this is what I do in my research world, et cetera, but these have been in the guidelines now for 8 years or more, and are a daily part of our conversations when I see patients with trainees, et cetera, and actually with families. They're on all the educational materials that are handed out to families as well. So I think it's a different scenario in terms of the comparison to diabetes. In terms of the question about uncomplicated versus controlled, I think there's a conceptual question, but then I think there's a data coding question. And I think the data coding question is is a point that should be well taken.
Okay.
And this is as someone who has analyzed Medicaid and Medicare data, that if the time point at which the change was made is not reflected in the actual alphanumeric code, there can be lots of misunderstanding about communication of when you analyze the data, interpreting your results. The conceptual question of uncomplicated or controlled, we typically don't, on a day-to-day practice basis, use the term uncomplicated with asthma. There are some patients, for example, who might have multiple conditions like cystic fibrosis plus asthma, or they might have some sort of other immune disorder that complicates their asthma. But for the most part, this is not a common day-to-day bread and butter lexicon of our practice. So I think from a conceptual standpoint and a coding standpoint, that capturing controlled with another number, probably does make sense to consider that. But I think the ultimate notion here and concept here is that it makes a lot of sense to capture control somehow, because it is a part of the daily management of an asthma patient.
Okay. Thank you.
Okay, yep.
Nellie Leon, she's St. American Hospital Association, and I want to reassure Sue that we're not worried about running out of ICD-10 questions. My concern is that knowing what physician documentation is today and knowing that we don't always get all the detail that we would like or that everyone else would like, I would recommend having an NOS option for all of the, just like how you have for the J45909, where control is the default for asthma NOS, that for the other versions where you have mild, intermittent, moderate, and so on, that you provide somewhere within that structure a place to document or code when you don't know, or there is no documentation of whether it's controlled, uncontrolled, exacerbated status asthmaticus, or whatever, because I'm concerned that if the documentation is not there, the coders won't know what to do, and then the doctors will get mad if they get asked, well, is it controlled or not?
Okay.
Thank you.
Thank you. Good suggestion. Any other comments, questions? Thank you. Infection following procedure, okay. All right, moving on. Our next presenter is going to be Dr. Garth Utter. We're on page 46 of our package, and the PowerPoint, I believe, is page 40. We're going to start discussing infection following a procedure. Dr. Utter.
Thank you, Cheryl. My name is Garth Utter. I'm a trauma and emergency general surgeon, and here today representing the Patient Assessment and Outcome Committee of the American Association for the Surgery of Trauma, which is, I should mention, the national specialty that encompasses emergency general surgical conditions. And just a brief word about why I'm here to present 4 proposals, I believe, this afternoon, and then 2 more tomorrow. Our organization is interested in trying to characterize the severity of different emergency general surgical conditions for the purposes of measuring quality, assessing trainee experience, facilitating clinical research and health services research, so a variety of different purposes. And it would help, we believe, to better leverage ICD-10 CM for these purposes. So the first of these proposals is, as you can see, infection following a procedure. And many of you are probably well aware that the CDC has pretty refined definitions of how to characterize surgical site infection and categorize it into 3 main categories. Of course, this is a very intense area of focus in terms of quality of care. Surgical site infections are a very common problem, perhaps involving as much as 2% of inpatient operations. These 3 categories generally are broken down anatomically by the CDC into superficial incisional infections, deep incisional infections, and organ or space infections. For example, the peritoneal cavity, the pleural cavity, the space inside the cranium. And these distinctions are important for a variety of reasons, but namely they're very important clinically in terms of determining the treatment involved and assessing the severity of the infection. This diagram depicts the categorization in a fairly understandable way, I believe, with the superficial incisional infections limited to the skin and subcutaneous tissue. The deep incisional infections extend down to the layer of the deep soft tissue, the fascia or muscle, and I believe there are equivalents for other regions of the body where that's not necessarily a germane distinction. And then beyond that is the organ or space surgical site infections. So as you might imagine, it's a big difference in terms of treatment. An infection of just limited to the skin or subcutaneous tissue might be opened, but it also might just be treated with antibiotics alone. Typically, an infection of that involves deep incision will be a little bit more serious problem, often does require reopening the wound and may involve some risk, for example, of dehiscence of the fascia and potential risk for evisceration, for example. And of course, a deep space infection really implies a fundamentally different problem involving the deeper structures that were operated upon. There are some concepts that are categorized along with the surgical site infections, at least in terms of the current T80 1.4 code, that are not really, get to the right slide here, that are not really the same as surgical site infections. And these include the relatively minor occurrences, sometimes termed stitch abscesses, which really, in a way, aren't infections at all, but perhaps just a robust inflammatory response to a foreign body. But at the opposite end of the spectrum is a condition such as postoperative sepsis, which may not be associated with a surgical site infection per se, but is potentially a very significant clinical problem. And as I mentioned, these concepts are really lumped together with other things that would be considered the more garden variety surgical site infections in the T80 1.4 code. We believe that it's really important to capture some of these distinctions as separate conditions, and that's really the basis of our proposed changes. We suggest that it would be worthwhile to require specification of the type of infection within the T80 1.4 group, and to keep that really as a category of codes that would capture distinctions among these three different anatomic categories: superficial incisional, deep incisional, and organ space infections, but also allow for the characterization of different processes, such as another type of surgical site infection, such as a stitch abscess, or conditions that really can't be characterized as any particular surgical site, for example, sepsis. And in addition, we would allow for the situation where simply the documentation wasn't adequate to describe what particular structure was infected or if one was infected. So Cheryl will review this, but this is just a brief synopsis of the classification we suggest. And I don't think I'll steal her thunder, but just mention that here's a way to contact me if you have any subsequent questions.
Does anyone have any clinical questions for Dr. Utter at this time? Okay, for PowerPoint page number 40, the proposed code modifications include at the T81, complication of procedures not elsewhere classified. Subcategory T80 1.4, infection following a procedure. It is being proposed that the following inclusion terms be deleted: intra-abdominal abscess following a procedure, post-procedural infection not elsewhere classified, sepsis following a procedure, stitch abscess following a procedure, and supraphrenic abscess following a procedure. Each of these inclusion terms are being proposed to be deleted. However, proposed new codes include T81.40, infection following a procedure unspecified. T81.41, infection following a procedure, superficial incisional surgical site, with inclusion term of subcutaneous abscess following a procedure. New code proposed, T81.42, infection following a procedure, deep incisional surgical site, with inclusion term intramuscular abscess following a procedure. Proposed new code T81.43, infection following a procedure, organ and space surgical site, inclusion term intra-abdominal abscess following a procedure, and supraphrenic abscess following a procedure. New code proposed T81.48, infection following a procedure, other surgical site infection, with inclusion terms stitch abscess following a procedure. And final new proposed code T81.49, infection following a procedure not elsewhere classified, and sepsis following a procedure. Do we have any questions?
Nellie Leon, she's saying, and this is a clinical question probably for the doctor. Would there ever be a situation where the same patient could have a post-procedural retroperitoneal abscess, because right now it's an excludes 1, with any of these other T codes? And the reason why I asked is that the excludes 1 means that the 2 codes could never happen during the same encounter for the same patient.
Yeah, I think that's a great point, and we should probably correct that so that they could co-occur in the same patient.
So it could be an excludes 2 instead, then, so they could occur in the same patient. Okay.
Yes, and quite honestly, I mean, I think we should also give some consideration. I hadn't maybe contemplated this particular issue, but that a retroperitoneal abscess could also be a deep or organ space infection code. So we may have to give a little bit of thought as to how to cleanly capture those concepts.
Okay, and a similar question then, and the obstetrical wounds are in a different chapter altogether, and that's probably like the C-sections and all of that. Is there any interest in tracking information about those kinds of infections in terms of, is it superficial or deeper?
Yes, I think that that's also reasonable to pursue that as well. It's obviously a much, much smaller proportion of all surgical site infections, but I certainly wouldn't be opposed to extending a similar classification to those codes.
Thank you.
Sue Bowman from AHIMA. I had a question about the stitch abscess being an inclusion term under T81.48. I guess if I hadn't seen it there as an inclusion term, I would have thought it would be considered, you know, like the superficial incisional site abscess. I'm not clear on why that would be different than some of the things that are categorized to T81.41 and T81.42 if it's a stitch abscess.
Yeah, she's questioning this.
So this gets a bit at the definitions that the CDC maintains, and they specifically do not include the term stitch abscess as a surgical, a superficial surgical, superficial incisional surgical site infection. I guess really the question is it an infection at all? I mean, I think most clinicians really simply do not consider it an infection. However, I think we are stuck with it. I believe it was already an includes term in the T81.4 code. So I don't know if we have flexibility at removing an includes term that already exists, or if it depends on if it's part of the WHO classification. But Moving it to a separate code was really just an attempt to try to preserve the concept of, according to the CDC definitions, for the superficial incisional category, but also not disrupt the prior includes terms for this code.
Okay, are there any other questions? Okay, we'll be moving on to the next topic for Dr. Utter. And this one is found on page 12 of your packets and slide number 2, PowerPoint slide number 2, abscess of anal and rectal regions.
Well, this is a topic that is also an interesting one, and I will spare you, although I have actual anatomic pictures in some of my talks, so I'll spare you the actual, patient pictures. Anorectal abscesses, it's really kind of a term that's used to describe any abscess in the perineal region that's presumed to arise from the anorectum. These infections generally are thought, according to, I believe, what's called the cryptoglandular theory, to arise from bacteria seeding into the perianal and perirectal tissue from one of the anal crypts. There are 4 main anatomic locations that every surgical or colon and rectal surgery textbook I've seen have used, and that is perianal abscesses as one category, ischiorectal abscesses as another, intersphincteric, and supralevator abscesses. These are pretty much constant terms that you find in treatises on this topic. So here's the one picture I will show you on this topic. This is a coronal section depicting the anatomy in the region, and it shows the 4 different categories in these green spots here. Usually the most easily recognized by clinicians is the perianal abscess. These are quite superficial, right near the anal opening. The next most common category is ischiorectal abscesses, which are a little bit deeper and usually a little bit more consequential in terms of leading to fistulas. There's also a category called intersphincteric, and I emphasize the inter because it's between the 2 sphincters rather than within a sphincter, and thus the distinction between the prefix intra. And then the 4th category, which is actually the rarest, and some even consider these really as, in a way, not even the same entity, supralevator abscesses, which could be thought of as a pelvic or even abdominal abscess, as it were. In the figure here, let's see, I don't think I have a pointer, do I? So I'll just draw attention to this wavy line in between the different colored tissue of the anal and rectal mucosa. That's what's called the dentate line, and these anal crypts are located at that level. What's thought happens is probably from a particularly hard bowel movement. It's possible that there's some minor trauma, disruption of that mucosal barrier, leading to some bacteria that traverses across it. And although the body generally has a really excellent blood supply in this region to fight off infection, sometimes the best it can do is wall off that infection, leaving it as an abscess. And what's really of consequence is how big this abscess is to a degree, its location, and in particular, if there's remains an opening that connects it to the rectal mucosa, and also if it tends to be creating an opening in the perineal skin as well. When both those exist, then that process has then converted to what we call a fistula in ano, or anal fistula, which is a condition that may require ongoing treatment. and potentially even an operation to facilitate healing. Because of this risk of a fistula, the location of the abscess is of some importance to surgeons, and particularly the opening of a tract into the anal rectum from the abscess. Depending on the location, that can make it important either to drain the abscess via the rectum, so transmucosally, in some cases, but in others it's best for the patient if we drain the abscess through the skin surrounding the anus. And so for these reasons, it is important to us to be able to distinguish amongst these four terms. In addition, some of this information is included here. It can help from understanding the epidemiology of these problems and the resources dedicated to them and appropriate health services administered. And so, as I mentioned, the perianal abscesses are the most common. Ischiorectal, the next most common. Intersphincteric and supralevator are quite a bit less usual. And as I mentioned, the treatment varies really by the category. The existing codes do not really allow for this standard categorization fully. However, they do capture some important distinctions. And the terminology is a little bit fuzzy, as you'll see. There's one code for K61.0 for anal abscess, which seems to fit pretty nicely enough with the perianal category that I mentioned. K61.1 is rectal abscess, which is a much more vague term, but it is one that clinicians use, and it's already in the existing classification, so we're not proposing to disrupt that. K61.2 is even really sort of, in a sense, less precise. It really, the term anorectal abscess really could apply to, I guess, any of the four different varieties that I described. K61.3 nicely matches with the ischiorectal category I previously mentioned. And then K61.4, I believe, although it's really a misnomer, I believe it does correlate with the intersphincteric abscess that I mentioned. What you'll notice is missing is that there is no code for the supralevator abscesses, although it's possible that one interpretation would be to apply the peritoneal abscess code K65.1 to this entity as well, at least for men, that is. I believe in women there's a different code. There's no way with any of these codes to indicate an infection that extends bilaterally, which is one important problem that we would bring to everybody's attention, is that one way of depicting the severity of an abscess is to be able to describe that it's enveloped around the posterior aspect, so it involves both sides. And so these we see as issues that could be remedied. So we propose changes that would add a code for the supralevator abscesses. All the other categories we believe can be kept as they are. That would be reasonable. And I believe since they're part of the parent ICD-10 classification, probably desirable. However, we might require greater specification of the laterality, mostly to be able to get a little bit more information about the severity of the condition. It's not necessarily important to be able to distinguish right from left in terms of severity, but it does help us understand, for example, if we have linked episodes of care, if there's been a recurrent infection or presumably an extension from one side to the other. The bilateral abscess specification would capture this quote-unquote horseshoe abscess concept that I have brought up. Of course, we would also want to allow for cases in which the documentation didn't make it clear which side was involved. So again, Cheryl will review these in detail, but the concept of what we're doing here is to take each of these existing codes, in this example, anal abscess K61.0, and provide 4 different subcategories, subcodes as it were, one for the right side, one for the left, one for bilateral, and then one for the side not specified. We propose that we would replicate the same pattern for all the different categories and add a category for superlevator abscess as well.
Do we have any questions for Dr. Utter for the clinical presentation? Okay, if not, on, again, page 12, slide number 2, for the code tabular modifications, in the essence of time, and not to reiterate just what Dr. Utter had specified earlier, we are basically adding for each of the codes under K61, abscess of anal and rectal regions, we're providing laterality codes, right with a 0.1, 0.01, left with a 0.02, bilateral 0.03, and a 0.09 for site not specified for all of the codes within that code category. That pretty much sums up the changes. Any questions or? Okay. Yes.
Okay, we will continue on with 2 more presentations from Dr. Utter. If you turn in the topic packet to page 48, the next topic is inflammatory disorders of breast. Dr. Utter.
Thank you, Shannon. So again, we'll sort of continue the series of somewhat similar types of proposals. In this case, our main interest is really to be able to distinguish cellulitis of the breast from an abscess of the breast. And so I think this will go fairly quickly. Mastitis is really a term that describes inflammation of the breast, but it's also could be considered synonymous with cellulitis of the breast, since the breast is basically a skin appendage, a skin structure. This inflammation, of course, can occur just as any cellulitis can, with or without infection, technically, although in most cases what we clinically mean is that there is an infection or a presumed infection. Infective mastitis is treated primarily with antibiotics. It's not generally treated with an operation, as are really all other forms of cellulitis in its simple form. Inflammatory breast cancer is one possible alternative diagnosis that should be considered by clinicians when there are potential predisposing factors for an advanced cancer, as well as any case in which there's a mastitis in a woman of an appropriate age who, for neoplasia risk, that is not responding to antibiotic treatment. Breast abscess, in distinction, is a collection of infected fluid in the breast. This is easy to occur because the breast contains ducts that, of course, fill with fluid physiologically. It's identified primarily by physical exam and using adjuncts of imaging, namely ultrasound is the test of choice to identify this pocket of fluid. The treatment has sometimes involved surgical drainage, but increasingly there's an emphasis on percutaneous drainage and trying to spare women unnecessary open procedures. Antibiotics, of course, are an adjunct to treating these infections. Interestingly, the classification of infections of the breast that occur during pregnancy do make a distinction between abscess and simple cases of mastitis, even though the issues, I believe, are really essentially parallel. The 091.1 set of codes concern abscess of the breast associated with pregnancy, the purpurium, and lactation. And then the 091.2 codes deal with non-purulent mastitis in these cases. And I believe by non-purulent mastitis, the emphasis is that it's not an abscess per se. So really, in parallel to what already exists for the pregnant state, we propose that the available code for inflammatory disorders of the breast, really, which encompasses both mastitis and abscesses, be subdivided, as it were, into a mastitis code and an abscess of the breast and nipple code, with the default option, if it's not particularly clear, to be the mastitis without abscess code. And so how this would look is basically like this. That's really all there was to this proposal.
Are there any clinical comments or questions before we look at the proposed tabular modifications? They're on slide 41. Maybe 42, if that's 42. Okay, great, thank you. Okay, so at category N61, inflammatory disorders of breast, we're proposing to delete the following inclusion terms: abscess of areola, abscess of breast, concubuncle of breast, infective mastitis, mastitis NOS, and to add 2 new codes: one, N61.0, mastitis without abscess, with the following inclusion terms: infective mastitis, mastitis NOS, cellulitis of breast NOS, cellulitis of nipple NOS. And the second new code, N61.1, abscess of breast and nipple, with the inclusion terms: abscess of areola, abscess of breast, concubuncle of breast, mastitis of with abscess. And at category L03, did that come up there? There we go. At category L03, cellulitis and acute lymphangitis, we would need to revise the exclude 2 note to read cellulitis of breast NOS at code N61.0. Are there any questions or comments? Seeing none in the room, I'll ask Dr. Utter to come back, and we will do the last of the 2 topics for today for him. Starting on page 54, the topic is mediastinitis, and Dr. Utter will come and do that clinical background.
Thank you. Well, our interest in making this suggestion really stemmed from trying to categorize the severity of certain emergency general surgery conditions, for example, perforation of the esophagus, such that we identified there's really no code to capture the very serious infections that occur into the deep chest space. And so a little bit of background on mediastinitis and why we need a separate code for it, we believe. Mediastinitis is an inflammation of the cellular tissue of the mediastinum, so the space in between the lungs and surrounding the heart. This is a condition that mostly occurs in a few particular circumstances. One of these is, as I alluded to, esophageal perforation. Once that the esophagus passes through the mediastinum, and once it perforates, it causes a bacterial contamination, which can lead rapidly to a very significant systemic infection. Another etiology is when infections occur basically as a deep organ space infection after a cardiac procedure, it's possible to develop mediastinitis. These tend to be not quite as severe as the former cases of esophageal perforation. And then another significant category, it's a little less common, but it is a well-known entity, and also a very serious one, is when a soft tissue infection descends from the neck. The tissue planes are really contiguous into the mediastinum, and this leads also to mediastinitis. So why do we care about mediastinitis, and why would we use that characteristic to classify the severity of certain types of infections? Well, it's a really scary condition to us. It's a very serious, rapidly developing infection for patients. When they develop it, we need to generally diagnose it in a very short time frame to be able to institute treatment to have a chance of of saving the patient in many cases, quite honestly. It carries a mortality rate that's varies depending on the condition and the tempo, but has been estimated as 10 to 50%. And really the treatment for it, although antibiotics are used as an adjunct, is in many cases to operatively drain the mediastinum and debride any necrotic tissue. So by all means an important entity in its own right. Unfortunately, as the classification currently stands, the concept of mediastinitis is actually separated from other infections of the mediastinum, which are captured in J85.3, for example, an abscess of the mediastinum. And mediastinitis in the current classification is grouped together with other conditions that really don't have anything to do with significant life-threatening infection of the mediastinum. Nonetheless, in this apparent classification, although we would keep the mediastinitis code where it is, we do recommend that at least it be separated from these other conditions of the mediastinum with its own code. And so we would propose really quite simply that J98.5 require an additional character to specify mediastinitis versus other diseases of the mediastinum that are not elsewhere classified.
Thank you, Dr. Utter. So Dr. Utter gave a quick summation of the proposed tabular modifications with the proposed two new codes being the J98.51. Thank you. It's slide 48, if you can, please. And then the second code being the J98.59. The one thing I think that was not brought out in his presentation was the proposal to delete the inclusion terms that are currently at the J98.5. So I'll list those and see if there's any comments or questions. Those inclusion terms are the fibrosis of mediastinum, hernia of mediastinum, and retraction of mediastinum. And then, as stated earlier, the addition of the two new codes. Are there any comments or questions on this proposal? No. Okay, she changed her mind. Okay. Okay. Thank you, Dr. Utter. I think that's it. So now we will go in our topic packages, if you would please, on page 37 for gingival recession. It's slide 31. Gingival recession involves the gums receding back and potentially exposing the roots of the teeth. And although it rarely results in tooth loss, gingival recession may affect thermal and tactile sensitivity because of the exposed dentin. In September 2011, at our CNM meeting, the American Academy of Periodontology submitted a proposal for gingival recession classification to be replaced by the Miller classification system. The previous submission has been withdrawn by the requester. The American Academy of Periodontology is now requesting that the specificity, which was in ICD-9 CM, be added to ICD-10 CM to differentiate the levels of severity for gingival recession. The proposed tabular modifications are at category K06, other disorders of gingival and odontolous alveolar ridge. The proposal is to delete the inclusion term under K06.0, gingival recession, deleting in the non-essential modifiers generalized and localized, and to add a note to read one code from K06.00 through K06.03 and one code from K06.04 through K06.05 be required for complete representation of gingival recession. The following list of codes that are being proposed: K06.00 for gingival recession unspecified, KO 6.01 for gingival recession minimal, KO 6.02 for gingival recession moderate, KO 6.03 gingival recession for severe, KO 6.04 for gingival recession localized, and KO 6.05 gingival recession generalized. Are there any comments or questions?
Jean Yoder, contractor for the Defense Health Agency. So is the gingival recession, can it be different on each arch? I mean, like the upper arch, can it have one and the lower arch have another? So I'm looking at this and I'm thinking, I don't think that gingival recession would be consistent for both arches necessarily. And so you might need to include which arch or which ramus of the arch, because if you had just one ramus, like this quadrant, you know, the upper right or something, I don't know, but I'd find out. It's one of those things.
Okay, thank you.
Hi, I'm Jean Narcissi from the American Dental Association, and I wanted to let you know, yes, that could happen. But also, the AAP was also requesting that post-infective and post-procedural be removed.
Okay.
And then what they're really asking for is that there can be a generalized gingival recession, and there can be a localized gingival recession, and those can be mild, moderate, and severe. So for each one of them, you could have 3.
Potential ones, correct.
Right, exactly.
Right.
And as far as the upper and lower arch, that would be identified in a different section of a claim, but it wouldn't be associated with the disease.
It might be in a different part of the 837D, but the thing is, so if on the claim, you might know which arch, but because if you have a code localized, minimal, and then you have another 2 sets of codes on the same encounter, generalized and moderate, that's not going to make sense if you don't specify which arch.
Well, you would specify.
But not in the diagnosis section. See, these codes in the diagnosis section wouldn't make any sense at all.
But unless you wanted to put
Well, yeah.
actual tooth numbers
Guess
in
what?
there.
Guess what? You got lots of spaces.
Okay, are there any other comments? Okay, hearing none, I will turn the podium over to Tracy Ramirez. Oh, 1 second, please.
I had a question for Jean Yoder. Jean, back to the microphone, please. Don't go anywhere. Since periodontology is asking for a return of the existing codes in ICD-9-CM, what's your experience with the use of the codes in ICD-9-CM?
Well, Donna, I don't know if you're aware, a year or so ago, the Department of Defense we submitted a huge package of codes, dental request codes, for endodontics, periodontics, whatever. We had a big one because there had been this Harvard proposal, and we saw it and we said, oh my gosh, if we don't get in fast, they're going to use up the codes and there won't be space for our proposal, because we send a lot of troops downtown, and so then we have a problem, because if some kind of, say, a filling or something fails, or whatever, and then they have to do it again, we want to know if it was a composite material or whatever. So we had sent that in, and so when I saw this show up again, I sent an email off, and I don't remember who it was. Oh, somebody behind you raised her hand. And I said, hey, what's the status of that big proposal that the DOD had put in? And it was, oh, I'll get back to you on that, or something similar, you know, I did not know you had done that. So I will send that whole thing again,
Okay.
and I will get Joel Knutson to contact you folks and talk about it. And I just asked Jean for her email.
Thank you, Jean.
Okay, if everyone could turn to page 42 in the topic packet. Hypertension in pregnancy. In slide number 34, the American Congress of Obstetricians and Gynecologists is proposing the revision of codes for hypertension and pregnancy. The suggested revisions update the code sections to mirror and standardize the existing language as it is currently reported in code sections 010 and section 015. The requested codes reference conditions complicating childbirth and the puerperium where they currently do not exist in 10 CM. And we're going to go over the codes. So at 011, they're proposing to add a code 011.4, pre-existing hypertension with preeclampsia complicating childbirth. And at 011.5, pre-existing hypertension with preeclampsia complicating the puerperium. At 012, gestational edema, they are proposing to add 012.04, gestational edema complicating childbirth. And at 012.05, gestational edema complicating the puerperium. At 012.1, gestational proteinuria, they are also adding 012.14, gestational proteinuria complicating childbirth, as well as 012.15, gestational proteinuria complicating the puerperium. At 012.2, gestational edema and with proteinuria, they are wanting to add 012.24, gestational edema with proteinuria complicating childbirth, 012.25, gestational edema with proteinuria complicating the puerperium. At 013, gestational hypertension without significant proteinuria, they are also wanting to add at 013.4, gestational hypertension without significant proteinuria complicating childbirth, 013.5, gestational hypertension without significant proteinuria complicating the puerperium, as well as 014, preeclampsia. They are wanting to add at 014.0, mild to moderate preeclampsia. They're wanting to add 014.04, mild to moderate preeclampsia complicating childbirth, as well as 05, complicating the puerperium, and so on and so forth, if everyone can see that. And at code 015, they are requesting to add complicating pregnancy at eclampsia there in the code title, as well as at 015.0, deleting in pregnancy and adding complicating pregnancy, 015.00, deleting in pregnancy and adding complicating pregnancy, unspecified trimester, 015.02, deleting in pregnancy and adding complicating pregnancy, second trimester, 015.03, eclampsia, deleting in pregnancy and complicating and adding complicating pregnancy, third trimester, and 015.1, eclampsia, deleting in labor and adding complicating pregnancy, and at 015.2, eclampsia, deleting the in and adding complicating in the puerperium. And at 016, they are also wanting to add a code for 016.4, unspecified maternal hypertension complicating childbirth. At 016.5, unspecified maternal hypertension, complicating the puerperium. And that is it. Are there any questions?
Nellie Leon, she's saying, oh, the slide just went away. I think you might have a typo because you've got 015.0 being eclampsia complicating pregnancy, and the 0.1 also says complicating pregnancy. Is that supposed to be the 015.1 complicating childbirth instead?
It could very well be. We'll have to double check
Because the
that.
0.0 and the 0.1 have the same title for that subcategory.
Okay, I see that.
Yeah. Okay, thanks.
Thank you for letting us know, Nellie. Are there any other questions?
I just have a question for Donna, I think it is. I was just checking with Nellie, and my brain is a little fuzzy. But I was just wondering, I think we had an EAB question that had to do with secondary pulmonary hypertension complicating pregnancy or something, and how that would be coded. And I don't know if you thought to ask ACOG how, if they wanted to include that as part of the proposal, or how that would be addressed, because I know we were struggling at the EAB, and I'm pretty sure it was secondary pulmonary hypertension. Do you remember that, Donna? Does that ring any kind of bell?
Yeah, I'll send that to ACOG and get a response from them. Any other questions? All right. Go to the next one. Okay. And our next topic is on page 66 in the topic packet, slide 61. It's risk level for dental caries. And the American Dental Association is proposing the creation of new codes that will assist dentistry with the reporting of detailed caries risk assessment diagnoses. These codes are needed to determine disease etiology factors, effective treatment modalities, clinical data collection, and population monitoring and research. The ADA is requesting the new code for consistency with recognized terminologies and to uniquely identify caries risk levels that are not currently represented in ICD-10 CM. So at Z87, under personal history of other diseases and conditions, Z87.1, personal history of diseases of the digestive system, we are proposing to add a new subcategory of Z87.12, personal history of other dental conditions, new code Z87.120, personal history of low risk for dental caries, new code Z87.121, personal history of moderate risk for dental caries, and new code Z87.122, personal history of high risk for dental caries. And I see we have questions.
Yes, this is Jean Narcissi from the ADA, and I just wanted to point out that these kinds of codes are necessary for quality measurement and the meaningful use program. But we originally had submitted them, proposed them for the dental caries section, the K02, because this measurement is really done on preschoolers, so, you know, the 3 to 5 year old children. So they may not have a personal history of caries risk. It may just be found out, or may be potential for future disease or disease risk. So I guess that was my question, if this is where they would fit. Is this where all the risk codes are going? It was just one of my questions.
Yes.
Even if they didn't have a personal history of it? Okay.
Typically, the risk codes are in the Z chapter. Putting them in the codes where the original proposal suggested, which was in the K codes, really would treat them more like a disease than a risk factor. So they were moved into this for the presentation. But we have other things like risk for fall. Most of the other at-risk codes reside in this particular chapter.
I had, I think, a follow-up question to Jean's, because I was confused when I read this. In the description of it, it sounds like the intent was to capture like people who are at risk, but to me, this sounds like they no longer have the risk factor. It went away because it says personal history of a risk for dental caries, and I think of personal history meaning in the past, they no longer have that risk anymore. And so I think that wording and having it in a personal history section is going to be very misleading and confusing. Because really what we're talking about is a current risk factor, not a history of a risk factor.
Okay. Please make sure you put your comments in writing. And now, Cheryl, please come up.
Okay, I'm back. Now we're on page 58 in our package, and it's also on slide number 51. And this is a topic that has been presented before on several occasions, and it's called Observation and Evaluation of Newborn for Suspected Conditions Ruled Out. The American Academy of Pediatrics, AAP, has developed modifications for its initial proposal presented in September 2013 CNM meeting. These modifications are based on comments submitted and working with various stakeholders over the last 2 years. Currently, ICD-10 does not have a way to uniquely capture suspected conditions ruled out as a reason for the encounter. The Academy originally submitted a proposal for a unique set of codes to be added to ICD-10 to more clearly capture this information. AAP, the American Academy of Pediatrics, is again requesting that a unique set of codes be added to ICD-10 to more clearly capture the information, hence the proposed development of the new codes category Z05, Encounter for Observation and Evaluation of Newborn for Suspected Diseases and Conditions Ruled Out. In addition, this revised proposal has additional modifications to include the revised code titles, inclusion terms, and clarification of an excludes to note. So, for this revision under the tabular modification, we're proposing to revise the note at section P00, newborns affected by maternal factors and complications of pregnancy, labor, and delivery at P00 to P04, for which the last sentence of this note has been deleted for clarity. So we're deleting these portion of the note, but without signs and symptoms, and which, after examination and observation, is found not to exist. These codes may be used even if treatment is begun for a suspected condition that is ruled out. So part of the revised proposal, again, we're revising the code note at the P00 to P04 section. We're also going to add an excludes to note under this section, which will be an excludes to that states, encounter for observation and evaluation of newborn for suspected diseases and conditions ruled out. Again, this is Z05, which is our proposed new code category. In addition to the revisions above, it is being proposed that the non-essential modifier suspected to be is deleted from each of the code titles and the inclusion notes where it is currently indicated. For example, at the P00, newborn, currently stating support suspected to be affected by maternal conditions that may be unrelated to pregnancy, it is being proposed that we are going to delete that non-essential modifier out of any of the code titles and inclusion notes. Another example for the revisions will include the revised code excludes note as well. Under the excludes to, we're going to revise excludes to newborn suspected to be affected by maternal complications of pregnancy at the P01 point dash. So anywhere where suspected to be, having all this written and said, is that where suspected to be is included as a code title, an inclusion term, or a non-essential modifier, we're proposing that we will delete this. We're hoping that this will bring more clarity to when these codes can and cannot be used at the P00 to P04. We're going to do this for each of the code categories at P01, P02, P03, and P04. The new code category is Z05, encounter for observation and evaluation of newborn for suspected diseases and conditions ruled out. This category is to be used for newborns within the neonatal period, the first 28 days of life, who are suspected of having an abnormal condition. There's a word there missing in that statement in your packets, but we will correct that. Again, suspected of having an abnormal condition, but without signs or symptoms, and which, after examination and observation, is ruled out. We've had different input from various stakeholders, and the overall consensus has been regarding this proposed category. We do have support for that as previously submitted. For example, new code Z05, observation, evaluation of newborn for suspected cardiac condition ruled out. Again, this provides a code for the encounter for the newborn when the conditions have been ruled out. Each of the conditions are pretty straightforward as far as the observation in newborn of evaluation for suspected neurological conditions ruled out, Z05.2, observation evaluation of newborn for suspected respiratory conditions ruled out, Z05.3, so forth and so on. There have not been any changes in this aspect of the proposal. The major change based on input has been because of the inclusion modifications of the suspected to be. And we have AAP is listing, so they will be welcome any questions or responses for this proposal. Yes.
Mr. Bowman from AHIMA, and don't look so terrified.
We're going to get this.
She's like, oh no, it's still not right. We in AHA have worked extensively with AAP and CHS on this proposal.
Your support has been fantastic. We appreciate it.
I applaud you for getting there, but I think there's just one little tweak that's missing.
Okay.
And that is the second to the last sentence in the note, the one right above the deleted one in the P note, also needs to come out, because the whole point of the changes, just for the people in the audience that might not have followed this issue as closely, was originally this category sort of mixed
Yes.
babies that had suspected conditions that had been ruled out with babies that actually had a condition. So the sentence that talks about for newborns who are suspected of having an abnormal condition resulting from exposure from the mother or the birth process, that sentence still needs to come out in
Okay.
order to be consistent with the rest of the proposal.
All right.
Other than that,
we
it looks
almost
great.
there. We've been working on this for quite a few years now. I appreciate all your help. And AEP, of course, is listening as well. Any other comments, questions? Yes. Okay, I'm done.
And again, just so people who may not have attended previously don't get the nuances here, this has been an ongoing issue for, 6 or 7 different meetings while we've worked to craft the words. When it was first developed in 10CM, we all looked at it, thought we had it right, and then each time after that, when we looked at it, there was something that wasn't quite right. So I'm hoping with this meeting, I know Cheryl is hoping, and everybody else on the staff and prior staff who have worked on this issue are probably hoping the same thing, that that we have finally nailed this down so that we can move forward with it for October 2016. So if you hear some giddiness, it's because I think we're just too happy that this may be nailed down for now. And hopefully nobody else will find anything. But I know we had a group of people who had not participated in the process before, and if you're still here or listening, please know that we would invite your comments, because a new set of eyes on this, I think, would be quite helpful to make sure that we haven't found yet one more thing that we've overlooked. So, okay, so with that, I'm going to have Shannon come back up to do a proposal. And then I will confer with David while she's doing her presentation to see which of his we might be able to also continue with for the rest of the afternoon.
Okay, so this next topic can be found on page 26 in the topic packet. It's slide 20. The topic is contact with knife, sword, dagger. And in 2013, the World Health Organization Update Reference Committee approved changes to ICD-10 category W25, contact with sharp glass, category 26, contact with knife, sword, or dagger, and category W45, foreign body or object entering through skin. These changes will take effect in ICD-10 in January of 2016. In March, at our CNM meeting here, NCHS submitted a proposal to address the changes that would be made in ICD-10. However, based on public comments, the request to differentiate further between a paper cut and that of a tin can lid, what we've done is we've gone back in and revised the proposal and would like to redo this and have you consider and give us your feedback. So, under the new revision, at tabular modification would be at category 25, contact with sharp glass, to add excludes to glass embedded in skin, W45, to revise category W26 to read contact with other sharp objects, to add excludes to sharp objects embedded in skin. Under that W26, this is where the additional codes would be further broken out, and the new codes would be W26.2, contact with edge of stiff paper with the inclusion term paper cut. New code to read W26.8, contact with other sharp object not elsewhere classified, inclusion term being tin can lid. And new code W26.9, contact with unspecified sharp object. At category W45, foreign body or object entering through skin, we would add and includes note to read foreign body or object embedded in skin, nail. To revise the excludes to note to read contact with other sharp objects. And delete the previous to codes W45.1 and W45.2. Are there any comments on the proposal and the changes? Seeing none in the room, I'll turn things over to Dr. Berglund.
All right, thank you. And we can just probably go forward to slide 25 here. I can probably do that myself if, let's see. And then I'll ask him to turn the slides back on. Sorry. Okay, and for those who are following along in their topic packets, let me look at that. This should be, actually, no, I want to actually jump forward even further. Let me look at this. No, I want to go to slide 32 and page 38. So I'm going to go forward a little more. And we'll be jumping around a little bit, I apologize. So we will start on slide 32, and we will be on page 38 in our topic packets. Again, so this one is on heart failure with reduced ejection fraction. And we've had a number of things we've done with heart failure over the years. Hopefully no one in the audience will feel like they are having heart failure and having to deal with this again one more time. But we'll just continue on and try to get these dealt with. So heart failure with reduced ejection fraction and heart failure with normal ejection fraction are or with preserved ejection fraction are the new terms that American College of Cardiology wants us to be using instead of the terms that we have now in ICD-10 CM with systolic heart failure and diastolic heart failure. So basically, it's been proposed that we add inclusion terms here related to the ejection fraction for the systolic heart failure and for the diastolic heart failure. I will comment that both of these are types of left ventricular heart failure. We'll get to that a little bit more in some other proposals that are related to these same subcategories. So, first off, ejection fraction is a way of measuring the left ventricular function. And with systolic heart failure, the ejection fraction is reduced. On the other hand, in diastolic heart failure, you have a normal ejection fraction or a preserved ejection fraction. And for that matter, since we also have combined systolic and diastolic heart failure, since it is involving systolic, there is a reduced ejection fraction. However, there's also a diastolic dysfunction. In the 2013 American College of Cardiology Foundation and American Heart Association guidelines, they had definitions of heart failure and noted these two principal forms of heart failure, the left ventricular failure, are heart failure with a reduced ejection fraction and heart failure with preserved ejection fraction. In their guidelines, they noted because other techniques may indicate abnormalities in systolic function among patients with preserved ejection fraction, it's preferable to use the terms preserved or reduced ejection fraction over preserved or reduced systolic function. So they also noted that in most patients, abnormalities of systolic and diastolic dysfunction will coexist irrespective of the ejection fraction. So now, in addition to that, with heart failure and reduced ejection fraction, they noted that those with left ventricular systolic dysfunction commonly have elements of diastolic dysfunction as well. So a lot of times you can have a combined picture, which might seem to be muddying the waters, but the bottom line is that if it's described just as heart failure with reduced ejection fraction, which is that presumably will be commonly used today since it is the language that ACC is now recommending. Based on the way that ACC is describing these as synonymous, if someone says heart failure with reduced ejection fraction, it should be reasonable to use the code or appropriate code for systolic heart failure. And these are subcategories, I will say. I don't show on this slide anyway, the way that these might be broken out. And basically we do have acute, chronic, and acute on chronic for those who aren't familiar with them directly. And we will be looking at that further because we are proposing to make some other additional changes. This particular proposal is, it might look just like an addenda type item in that we're just proposing to add inclusion terms. So in some respects, this would be like just an addenda item, but we're making it a separate complete topic because it does have impact in a few places. So the bottom line would be that heart failure with reduced ejection fraction would be considered systolic heart failure. And at I50.3, diastolic heart failure, we would also propose to add two other alternative terms, heart failure with normal ejection fraction and heart failure with preserved ejection fraction. HFpEF would be another way, or for back at the I50.2, the systolic. Heart failure with reduced ejection fraction can also be labeled as HFrEF. And finally, at I50.4, combined systolic and diastolic heart failure, since we also have that, it's being proposed that we add the inclusion term heart failure with reduced ejection fraction and diastolic dysfunction. For completeness and consistency, that seems a reasonable approach to add also from my standpoint. So that is the summary of this particular topic by itself. I will say we will be touching these same codes further and reviewing and proposing a few other changes to them with the next topic. So you can look forward to that also. Any comments on this as it stands?
For completeness, at I50.4, the combined systolic diastolic, wouldn't you want to have the same language that you have for diastolic? So in other words, heart failure with reduced ejection fraction and preserve ejection fraction?
No. So the ejection fraction, essentially there's a cutoff level, and if it's above that level, it's preserved or normal, and if it's below that level, then it's reduced. If you've got combined systolic and diastolic failure, though, then you're using, basically you're noting that there is a reduced ejection fraction, but in addition to that, there's some additional things going on that are a problem with the diastolic function, so there is some diastolic dysfunction also. So the nice thing about looking at the ejection fraction is you can basically usually just look at it as the ejection fraction percentage is this percent of the blood that's in the heart to start gets pushed out. And if the ejection fraction is above a certain percent, then it's good. And if it's below a certain percent, then it tells us that the heart's not pumping as much blood as it should be. And in systolic failure, that's basically based on a simple assessment there. Essentially, the left ventricle is not pumping as much blood through as it should be, and there's this reduced ejection fraction. In diastolic heart failure, essentially there's a problem often with the ventricle filling. You're not getting enough blood into the heart to start with, and so then you're not pumping enough blood, but it's not because you don't pump as high a percentage of the blood that's in there as you should, it's because you didn't get enough blood in there to start in general. But in the combined case, you're not pumping as much blood as you should have, but you also weren't getting as much in there to start with as you should have. So it's essentially, in the combined, you've got two problems going on, but we can't just use the same terms. We can't say that the ejection fraction was both reduced and it was normal.
Okay, because just being very simplistic.
Sure,
One,
sure.
1 + 1 = 2, right?
I know, it
So
seems like it should
one-
work that way at
right,
first
so
glance, but
systolic being 1, diastolic being 2, and then we're saying this one is combined, so it sounded like it should have both terms to be consistent, like the inclusion terms should be consistent. Because, what you're talking about is a clinical
yeah,
differentiation.
it's more of a clinical definition, and
Right.
it's a little bit of a difference. The combined is a little different. But basically, ACC is now telling everyone that when you're talking about this, instead of calling it systolic and diastolic, please tell us about the ejection fraction instead. And all the cardiologists are dutifully recording it that way. And then all the coders are going to say, but you didn't tell us if it was systolic and diastolic. And then the doctors are going to say, but we're doing what the ACC told us to do. If you have a problem with that, go talk to the people at Coding Clinic and
Oh, yeah, no.
bother Nellie.
But I guess, I'm even more concerned because, again, as coders, we are looking at the documentation. So you're saying I will never see in the documentation both a reduced and a preserved ejection fraction.
No,
So
they should never say that together.
Okay.
Essentially, they use a cutoff number, and if it's above that, then it's normal or preserved, and if it's below that, it's reduced.
But they will see systolic heart failure, diastolic heart failure, or some of those terms. So they
Sometimes,
can
they might
make-
sometimes talk about that. Or they might say that they have a reduced ejection fraction and they have diastolic dysfunction. And if we saw both those terms together, then we should be able to say that it's a combined systolic and diastolic.
So they can make that connection themselves. I'm just asking because, coders get very specific about what is documented and what they can interpret or not interpret. And so just that.
Yeah.
Okay.
And usually if there's heart failure, most of the time it's left-sided, left ventricular heart failure. And the way that they differentiate this into different types typically will be the more common one is the systolic heart failure, where they have a reduced ejection fraction, where basically the amount of blood that's in the left ventricle to start that the heart pumps out is not as much as it should be. Maybe it's less than 40% or something like that gets pumped out. So, and that's a bad sign, because usually more than, it should be quite a bit more than 40%. It should be well over 50% of the blood gets pushed out, essentially. So the other things that can happen, though, is essentially you might be pushing that higher percentage of blood out, but you didn't have as much blood in the heart to start with, and then you have diastolic heart failure, or heart failure with preserved ejection fraction. So you're pumping the right percentage out, but you didn't have as much in there to start, so you're not moving as much blood through, is the bottom line. Or in combined, you had problems with both. You didn't start with enough blood in there to start with, and you didn't pump as much as you should have out either. So then you've got both problems, as it were. But when you just look at the basis of the ejection fraction, then you'd either have a reduced ejection fraction or you'd have a normal preserved ejection fraction. And those are the primary things they want to look at right now, or what the ACC is asking that physicians record, and that they use that as the way of defining and describing things. So, all right. Other comments or questions on that? Hopefully it's at least as clear as mud, or a little more clear. Hopefully more. All right. So I did promise we were going to talk about a few more things related to heart failure. And next I wanted to jump to end-stage heart failure, which is on page 29 in your handouts, or it is slide 25. And I'm going to try to back up to slide 25. And there we are on slide 25. End-stage heart failure, and also we'll talk some about right heart failure and biventricular heart failure. But I will first talk about the end-stage heart failure. So end-stage heart failure And first off, I will comment that the end-stage heart failure, and as far as it goes, the systolic and diastolic heart failure, as I'd said before, these are both types of left ventricular failure. So that's not always been as clear from our coding terminology, and from the codes that we have, we don't necessarily make it clear that we're talking about left ventricular failure. Although, as an aside, we do have, at this point, right heart failure is going to an unspecified code, which is kind of sad because it really is more specific than an unspecified code should be. And so it has been proposed that we make that more specific also, and we'll be coming to that. But first, we're going to look at end-stage heart failure. And at the same time as we look at end-stage heart failure, we'll look at essentially a proposal to add some left ventricular to each of these existing codes. So we'll be looking at that kind of at the same time. And as a comment, this kind of goes along with the right heart failure in that it's helping to clarify that our existing codes, which are related to left heart or left ventricular failure, are intended to be applied that way, and we're adding some terms to make that more clear. So we've had a few things here. I talked also about having acute and chronic heart failure. End-stage heart failure is a type of chronic heart failure. Patients with end-stage heart failure fall into stage D of an ABCD classification that the American College of Cardiology and the American Heart Association use. People with this end-stage heart failure are characterized by an advanced structural heart disease. They have pronounced symptoms of heart failure at rest or on minimal physical exertion, despite a maximal medical treatment. They frequently become intolerant to medical therapy. They often develop worsening renal function. They may have diuretic resistance based on current guidelines. The patient population with end-stage heart failure have a one-year mortality rate of about 50%. They're at the highest risk for being rehospitalized. They often require special therapeutic interventions such as ventricular assist devices. They may require an artificial heart or heart transplantation, or they may require hospice care as another alternative. So basically, the people with end-stage heart failure are the very sickest, the people who need the most help, the most intense treatment, if you like. So it's being proposed that we expand for the different types of chronic heart failure to basically specifically be able to capture cases that are end-stage heart failure. Our coding proposals here do, as it were, combine a few things. We have an existing code, I-50.1, which is a WHO code, I will comment. It's left ventricular failure. Now, I have just said that our systolic and our diastolic heart failure are specific types of left ventricular failure. So while we have been using these terms and codes in ICD-10 CM in more or less the same way, just to make clear, the I-50.1 essentially is left ventricular failure unspecified, and we'd like to make that explicit and add that to the title just to make that clear. And we wouldn't usually use the term left ventricular failure if we have a more specific identification as to whether it's systolic or diastolic, or as we were just noting, whether it might have either normal ejection fraction or reduced ejection fraction. Also, we would want to identify that as part of it. So part of the proposal is to add unspecified at I-50.1. Next, at I-50.2, systolic congestive heart failure. It's proposed that we revise the title at I-50.21, the code acute systolic heart failure. We would add and make it acute left ventricular systolic congestive heart failure, with left ventricular also being a non-essential modifier. So we don't have to have that, but if it's mentioned, then it does end up being included here. This will help clarify, but it won't be a required term, as it were. Then we also are proposing to revise at I-50.22, chronic left ventricular systolic congestive heart failure. We would add left ventricular to the title there. And now we are proposing to add some new codes. We would add a new code I-50.220 for chronic left ventricular systolic congestive heart failure without mention of end stage. A new code I-50.221 for end stage left ventricular systolic congestive heart failure. And additionally, a new code, which I'll have to go forward one slide to show you, I-50.229 for chronic left ventricular systolic congestive heart failure, undetermined classification. So, additionally, we would have a revision here at I-50.23 for acute on chronic. We would add left ventricular systolic congestive heart failure. And then we would add new codes here also for I-50.230, acute on chronic left ventricular systolic congestive heart failure without mention of end stage. A new code I-50.231 for acute on chronic end stage left ventricular systolic congestive heart failure. And a new code I-50.239, acute on chronic left ventricular systolic congestive heart failure, undetermined classification. So those are the proposed changes for systolic heart failure. Next, we'll look at diastolic heart failure. And at I-50.3, diastolic congestive heart failure, we would propose to revise I-50.31, and so it would become acute left ventricular diastolic congestive heart failure. We would revise I-50.32, so it would become chronic left ventricular diastolic congestive heart failure. And we would add new codes there, I-50.320 for chronic left ventricular diastolic congestive heart failure without mention of end stage. And looking at that, we didn't get left ventricular in parentheses as we should have, but we would plan to do that also. My apologies. I-50.321, we would have end-stage left ventricular diastolic congestive heart failure. And I-50.329, we would have chronic left ventricular diastolic congestive heart failure, undetermined classification. So that is the chronic by itself. Additionally here, we would have I-50.33, acute on chronic left ventricular would be added to the title, diastolic congestive heart failure. And we would create new codes, I-50.330, acute on chronic left ventricular diastolic congestive heart failure without mention of end stage. And again, left ventricular should be in parentheses there. A new code I-50.331, acute on chronic end stage left ventricular diastolic congestive heart failure. And a new code I-50.339, acute on chronic left ventricular diastolic congestive heart failure, undetermined classification. And finally here also, we would add at I-50.4, combined systolic and diastolic heart failure, we would revise I-50.41 to add left ventricular to the title, so it would be acute left ventricular combined systolic congestive and diastolic congestive heart failure. We would revise I-50.42, also adding left ventricular, so we'd have chronic left ventricular combined systolic and diastolic heart failure. And we would create new codes there, I-50.420, chronic left ventricular combined systolic congestive and diastolic congestive heart failure without mention of end stage. A new code I-50.421, end stage left ventricular combined systolic congestive and diastolic congestive heart failure. And a new code I-50.429, for chronic left ventricular combined systolic congestive and diastolic congestive heart failure of undetermined classification. Now, Finally, I-50.43, acute on chronic left ventricular would be added to the title, combined systolic congestive and diastolic congestive heart failure. We would add new codes here, new code I-50.430 for acute on chronic left ventricular combined systolic congestive and diastolic congestive heart failure without mention of end stage. I-50.431, acute on chronic end stage combined systolic and diastolic heart failure. And a new code I-50.439 for acute on chronic, again, left ventricular combined systolic congestive and diastolic congestive heart failure of undetermined classification. And that is all of those proposed changes. Any comments or questions on these, in-stage related or the adding left ventricular to the titles here?
My question has to do with the undetermined classification. That seems like introducing a new term here that we don't normally have, and I assume it means clinically undetermined by the physician, which means it would have to be documented as such. And I'm worried, that's going to be difficult to capture in the documentation and potentially get mixed up with the without mention of end stage, where people, they're going to end up being used interchangeably as two different ways of saying unspecified.
We'll hope that that would not be the way that they would be used, but that is certainly a legitimate concern, I would say. What does undetermined classification mean there? Yeah, basically, you are, I think that is correct. We would be intending that to be meaning that the doctor couldn't tell, essentially, rather than just that it's unspecified. And certainly it does raise the question of why did they not say, or why did we not know? And ordinarily, either they would say it's end stage, and then we've got a specific code for it, or if they didn't say it was end stage, then they should be able to go to the other code that is without mention of end stage. So certainly undetermined classification is a little bit less clear, and why would one use that rather than one of the other two? So would you feel we should only have two? That would be your preference. So your preference would be that we don't add as many codes as this proposal does. Okay.
Yeah,
Yes.
Nellie Leon, she's saying, I guess for me, I wasn't sure if this was another level of classification by the American Heart Association, or was that meant to be something like clinically undetermined, or was it really unspecified? I guess that's where I didn't know where the terminology was coming from, or what is it really? Yeah, which classification? Because we talk about ICD-10 being a classification system. Is this a classification of heart disease? What classification? I mean, and maybe you can clarify that. No. That's
a very reasonable question. Yeah, and we had this proposal. Now we didn't say where this one came from. This did come from a practicing cardiologist. And this was the language that he proposed. I've not gone through to verify as to whether ACC uses the language of undetermined classification or how they would be doing that. We do have all of these off to ACC to see if they give us further comments, but I do not think they had commented on this proposal specifically as yet. They had commented on some other things we'd sent them. But we'll see what their comments are on this. Certainly the idea of cutting it back to only have two would be something we could certainly consider. And if somebody does say that it's an undetermined classification, well, that doesn't mention end stage, so we could put them there. That would be something that we can certainly contemplate, and I appreciate your thoughts on this matter. And I'll appreciate everyone to put your thoughts on this in writing too. So, and that could simplify things and give us a bit fewer proposed new codes, which wouldn't be a bad thing either potentially. So, All right. As an aside, I talked to Linda Holtzman briefly, and she was asking where these came from, in part because, as she told me, she won't be here this afternoon or tomorrow, but she's going to be soon going and talking to a group of annoyed cardiologists who were wishing that we had fewer codes. So I don't know what to tell people, because then we get other proposals like this, which came from a cardiologist and said that we needed more codes. So there can be disagreements on this matter, clearly, but we'll do our best. If we can't make everyone happy, at least we can make everyone unhappy in different ways. We'll see what we can do that way. All right. So I do welcome comments on this, though, definitely. And we'll see what we can do. As I said, we'll see if we can at least keep some coders happy if we can't make all the cardiologists happy. How's that? I thought that might fly better in this audience. We'll see. Don't tell the cardiologists I said that, though. I know. It was kind of a joke. If you could get any cardiologists to watch this tape, maybe they would actually comment. That could be a good thing, too. So I won't feel too badly if they do want to watch it. Any cardiologists watching this out there someplace? We welcome comments. We really do. We invite them, please. So, okay. Going on now, if there's no more comments on this topic, we are going to move on to another heart failure topic. This is high output heart failure, and those following along in your handouts, it is on page 41 or on slide 35. So slide 35, and I believe I'm there now, actually, so we could probably turn that back on, and again, it is on page number 41 for those who are following along. And this one is a little bit simpler. It is high output heart failure. And basically, high output heart failure usually it's a little different than most other types of heart failure. And I will comment, I'd mentioned right heart failure, and I will be coming back to that, but I'm first going to do high output heart failure. High output heart failure usually manifests with warm peripheral extremities, pulmonary congestion, at times low blood pressure despite a high cardiac output, usually an elevated heart rate. It's usually due to some other underlying cause. Now, you can say that for most heart failure, it's usually due to some other cause. But high output heart failure is a very specific type of problem. Its causes are different from most types of heart failure. The underlying conditions that may cause high output heart failure include arrhythmias, anemia, fistulas, thyrotoxicosis, sepsis, carcinoid syndrome, polycythemia vera, Paget disease of bone, among other things. While high output heart failure is a very specific type of heart failure, right now in ICD-10 CM, it's indexed to code I50.9, heart failure unspecified. And we do not have an other type of heart failure, I'm afraid. So, this proposal, based on multiple inputs and some previous discussions with some other internists, it's proposed to add a new code for high output heart failure. And it is proposed that we add at I50 heart failure a new subcategory I50.8 for other heart failure, and a new code I50.81 for high output heart failure. We could contemplate adding an I50.89 for other heart failure not elsewhere classified, in case there's anything else that we haven't covered yet. So that's not in this proposal at this point in time. I'd certainly be glad to take input on that, though. So I'll ask right now, and we'll probably put that in the summary. Would it be useful to create an I50.89 for other heart failure that's not elsewhere classified? Thank you. That's, yeah, the ICD-9 code part of it definitely isn't something we want. But septic shock can be one of the things that can basically look similar to a high output heart failure, where essentially you're having a hard time keeping up your blood pressure despite a very high cardiac output. But sepsis can be a cause of high output failure.
So that would be an excludes
So we would
two.
probably want, well, we could use an excludes one or an excludes
No,
two, but
excludes
essentially,
two.
well, if we wanted to use, well,
Yeah, because if you
yeah.
have it, code it too.
well, we could allow coding it also, yeah, or coding it too. Essentially, if they have septic shock, we'd be able to use a code for that. And we may not need the high output heart failure to be recorded. But essentially, the clinical picture in septic shock is of a high output heart failure. So if you're familiar with that, then that gives you a picture of what it's like. Sue? Yes?
Yeah, I don't think we need an excludes note at all, because if
Okay.
it's documented as septic shock, I don't think you're going to be at the high output heart failure.
You're
code.
probably right. So yeah, we may not need that. Yeah. So we may not need an excludes note. We can just presume that it'll be documented that way usually. Okay. Other comments or questions or thoughts on this? I'll definitely invite everyone to put thoughts on writing on this one. And again, as well as what we have there, it could be of interest whether it would be useful to have an I-50.89. So, okay. Next, we will want to look at the at right heart failure, for which I may need to back up. Let me see here. I'm trying to sort out where that is, actually. I believe it is in your handouts. That's on page 32. And let me see if I am able to find this in our okay, let's see. All right, did we lose those? I'm not sure where these went in our slides. Okay, I'm not sure if I have slides for right heart failure. Those may have gotten lost along the way. In any case, I will discuss those whether we have slides for them or not. And those following along in handouts, we will be on page 32 and 33, and we will work through the clinical material on page 32, and then we will cover things that are on page 33 that we may not have slides for, and that's life if we don't. We'll just go from there. So right heart failure and also biventricular heart failure. First, there's a number of different issues here. First, chronic right ventricular failure can have similar characteristics and similar causes to left ventricular failure, but the consequences can be quite different. You can get hypertrophy of the right ventricle due to pulmonary hypertension with both primary or secondary causes. As an aside, we'll talk about pulmonary hypertension a bit more tomorrow, but that will be, that's a matter of foreshadowing of what you'll hear tomorrow. In any case, there can also be dilation of the right ventricle due to ischemic disease or due to toxicities or alcohol. You can have chronic right heart failure caused by valvular disease, such as mitral regurgitation or tricuspid or pulmonic valvular disease. These need to be differentiated from left heart failure in patients with end-stage renal disease. The cardiomyopathies can be basically the same in how they are described and in the types of things that cause them, but where left heart failure will cause a backup into the lungs and then a decreased perfusion to the systemic organs, a right heart failure would cause a backup into the venous circulation and also a chronic passive congestion of the liver and a so-called cardiac cirrhosis. It can also contribute to secondary hypercoagulable states that may then cause an increased risk of pulmonary embolism. There may be signs of jugular venous distension also that demonstrate the increase in the venous pressure. chronic core pulmonality, or chronic right heart failure, essentially chronic core pulmonality means the right ventricle is hypertrophied in response to an increased resistance to flow through the lungs. And in patients with chronic lung diseases, these can be linked to the right heart failure. Currently, none of the other possible causes of chronic right heart disease can be linked that way with right heart failure. And we've not had a code for chronic right heart failure either. Right side dominant heart can develop without failure, and presence of a chronic core pulmonality may not signify that the right ventricle has failed, but just that it's responded with hypertrophy to a chronic lung disease. Acute core pulmonality signifies an acute dilation of the right ventricle. It's usually a response to a massive pulmonary embolism or to significant adult respiratory distress syndrome, where basically there's problems with moving the blood through the lungs. We do have codes for those two conditions, the pulmonary embolism and ARDS, in 10cm. Acute core pulmonality will usually be associated with an acute right heart failure. It can resolve totally after the insult, presuming that the person survives. There are also other causes of acute right heart failure, and those haven't had a way to demonstrate them or to capture them in ICD-10cm. Now, so as it stands right now, in addition to right heart failure, code I50.9 in ICD-10cm includes biventricular failure, and it does not let these be differentiated in any way. Patients with biventricular failure can have a right heart disease due to one cause and a left heart disease due to another. Most cardiomyopathies will affect the whole heart, and thus both the right and the left ventricles, but there can be other types of cases, and there's a need to be able to distinguish cases like this from those with different causes. And patients with biventricular failure may be eligible for heart transplant, well, as others may also. Looking at the proposed code changes here related to right heart failure, at I50, we have at heart failure, it's proposed that we add a new subcategory, and those following along in the handouts. At this point, we're proposing a new subcategory I50.5 for right ventricular heart failure, and then a new code I50.50 for right ventricular heart failure unspecified, a new subcategory I50.51 for isolated right ventricular failure. Also, we want to have a code also note there, code also causative disease if known. We would add new codes I50.511 for acute isolated right ventricular failure, and a new code I50.512 for chronic isolated right ventricular failure, and a new code I50.513 for acute on chronic isolated right ventricular failure. And we would have inclusions there also for acute decompensation of chronic isolated right ventricular failure and acute exacerbation of chronic isolated right ventricular failure. We would also add a new code I50.52 for right heart failure due to left heart failure, an inclusion there for right ventricular failure secondary to left ventricular failure, and a note to code also the left ventricular failure. And that would use one of the I50 codes, I50.1 to I50.43. And we would also add a new code I50.53 biventricular heart failure with a note to code also the left ventricular failure. As to noting to code also the left ventricular failure, just as an aside as to what that lets us capture, that would let us tell whether the left ventricular failure was systolic or diastolic primarily, or whether it was identified as having reduced ejection fraction or normal ejection fraction, if you prefer, as ACC would want us to use the language. And finally, also at I50.9, heart failure unspecified, we would delete the inclusions for the biventricular failure and the right ventricular failure, which we were creating specific new codes for. So any questions or comments on those proposed changes? And I apologize, we don't have the changes in front of us here, but hopefully we've got printouts among everybody.
Okay, so for I50.53 biventricular heart failure, you already know both ventricles have been affected.
Yes.
I don't think, for those cardiologists who think there are too many codes already, I don't think that the I-50.1 actually adds anything because it just says left ventricular failure unspecified. I do see that the others do provide information, systolic, diastolic. So could we change that parenthetical to just have it start at I-50.2?
We could make that code also the type of left ventricular failure and have it go, from the I-50.2. We'd probably want to say if known then.
If known or something along those lines.
And then presuming that it's not known, presuming it's known, then we can code that. And if it's not known, as you say, it doesn't add anything, so it would be fine not to include that. Okay. Thank you for that suggestion. I think that's a very helpful thing to clarify, and so we don't need to add an extra code if it doesn't tell us anything. All right. Any other comments on the proposed changes related to right heart failure? And again, the right heart failure proposal did come from the same cardiologist as the end-stage heart failure proposal too, just as an aside. Okay, seeing no other comments there, I will next want to move to atrial fibrillation, another heart-related issue, and this will be on page 20 in your handouts or on page 12 in the slides, so page 20 and 12. And I may be able to go back to 12 here, although it might take me a little while. Let's see. It's not moving when I push the button. Does this one work too? I don't know. We'll see. Slowly making our way to slide 12. We're on 15, so we're getting close. Okay, and here we have atrial fibrillation. So first, talking about the clinical aspect of this, atrial fibrillation is an important clinical issue. It's a common cause of an abnormal, irregular heartbeat, and basically your heart wall doesn't move normally in atrial fibrillation. The sinus node is not where the source of the heartbeat is coming from. There may usually be multiple different places that the heart rate is starting from in atrial fibrillation, and so it's kind of irregular and the heart's not beating in a coordinated way, essentially. Now, that lack of normal motion means the heart wall doesn't move the same way regularly, and that makes a higher risk of blood clots forming in the heart with a subsequent higher risk of thromboembolism, and that can include thromboembolic stroke. Atrial fibrillation is generally treated by electrical or pharmacological cardioversion. So essentially you want to get them converted back to a normal sinus rhythm. And usually you can do that either with an electric shock or with certain medications. It can be important to be able to identify whether a particular case is a first detected case of atrial fibrillation or a later recurrence. The first detected atrial fibrillation is a case where there was no prior history, no known or available prior history of atrial fibrillation, so no certainty about presence or absence of prior episodes or duration of an episode. First detected episodes of atrial fibrillation are classified as paroxysmal when they terminate, or persistent when they last for more than 7 days, more than a week. Paroxysmal atrial fibrillation is an episode that's terminated. It can be terminated either spontaneously or due to cardioversion within 7 days of onset. Paroxysmal atrial fibrillation may involve termination of the first episode of atrial fibrillation or termination of an episode of recurrent paroxysmal atrial fibrillation if there were prior episodes. Persistent atrial fibrillation is the term used for cases that do not terminate within 7 days or that require repeated pharmacological or electrical cardioversion. Additionally, long-standing persistent atrial fibrillation is persistent and continuous atrial fibrillation that lasts longer than 1 year. And permanent atrial fibrillation is persistent or long-standing persistent atrial fibrillation where the cardioversion is not indicated or cannot or will not be performed. And additionally, the term chronic atrial fibrillation may refer to any one of or each of persistent, long-standing persistent, or permanent atrial fibrillation. In usual clinical practice, one of those other more specific terms would be preferred. Now, atrial fibrillation may be associated with a normal pulse rate or with atrial tachycardia, a fast heart rate, which is common, or also with atrial bradycardia, or potentially with alternating appearance of tachycardia and bradycardia. That can be a tachybrady syndrome. You can have that with a sick sinus syndrome also. We've seen some things with that. So there can be a number of things that can occur in these cases. Atrial fibrillation is frequently associated with a mitral valvular disease, particularly with mitral insufficiency. And you can have more blood flow there. So essentially things that can cause increased blood flow and a dilation of the atrium can contribute in that case. So treatment of patients with disease of the mitral valve can be significantly different than treatment of patients with atrial fibrillation that's not associated with mitral valvular disease. So a distinction there can be important to be able to identify and track. So it can be very important to be able to specify that. Now, we would generally use separate codes for that, I will say. Looking next at the proposed tabular modifications for this proposal, we have category I-48, atrial fibrillation and flutter, and I-48.0 is paroxysmal atrial fibrillation. The I-48.0 here also, we have a code also note, code also if present, bradycardia, mitral valve insufficiency, rheumatic mitral insufficiency, tachycardia, or tachycardia bradycardia syndrome. So all these are with paroxysmal atrial fibrillation. I will note paroxysmal atrial fibrillation is a code that we got directly from WHO. I will also note in our discussion and looking at this, we did put code also, the code also note at the subcategory level here. We probably could put a single one at the category level, and that might simplify things. We'd welcome comments on that, but essentially the code also if present is probably applicable for all of atrial fibrillation and flutter. So we may want to just put that at the category level. Moving on, looking at I-48.1, persistent atrial fibrillation. Again, we've got, in this case, it's the same code also note. Also looking at I-48.2, chronic atrial fibrillation. I will note that all these are from WHO, the persistent one and the chronic one here also. We're proposing at chronic atrial fibrillation to add new codes, essentially for I-48.20, chronic atrial fibrillation unspecified. Remember, as I'd said, there's three usual types of chronic atrial fibrillation. If all we know is that it's chronic atrial fibrillation and it's unspecified, we'd code it there. We'd also create a new code, I-48.21, for long-standing persistent atrial fibrillation. That way we would more specifically capture the long-standing persistent cases. And then finally also a new code, I-48.22, for permanent atrial fibrillation. So these are a bit more specific, and they would let us capture each of the specific types of chronic atrial fibrillation, or also if it was unspecified as to what type of chronic atrial fibrillation, we would have that also. Now, one of the other things of interest that I'd mentioned was first detected atrial fibrillation. It is proposed that we create or have an I-48.8 other atrial fibrillation flutter and create a new code I-48.81 for first detected atrial fibrillation. And this would be used with the other types of atrial fibrillation. So we would note code first the type of atrial fibrillation, such as the paroxysmal atrial fibrillation or persistent atrial fibrillation. We would also propose to add a new code, I-48.89, for other atrial fibrillation and flutter. And we would also be coding other additional things also if present. Next, we would, at I-48.9, we have unspecified atrial fibrillation, and we could add this code also note there also, or if we put that code also note at the category level, then we might not need to add that to all the different codes that we have there. And that covers all of the proposed changes in this proposal. Any other comments on this? Questions or remarks?
Sue Bowman from AHEMA. I didn't catch whether you said whether the American Heart Association or, you know, the clinical cardiology groups had looked at this proposal or not. I guess I'm wondering about this level of detail and whether it would be documented, like persistent versus long-standing persistent, and then whether it would really be documented that this is the first detected atrial fib. And I'm just wondering whether this extensive level of detail is really necessary or will be typically used.
A good question. The recommended terms from what I've seen from ACC documentation, at first I will say we did send this off to ACC and we got some initial comments at least about some issues in 10cm in general, but at this point not definite whether they basically would support exactly these changes or not. So we're waiting on some further comment about this. The bottom line there, they do recommend identifying the types of chronic atrial fibrillation as persistent, long-standing persistent, or permanent. So yeah, hopefully so, huh? In other words, well, from what they'd said, it looks like they should get one of those terms used rather than the term that we got from WHO was persistent atrial fibrillation and then chronic atrial fibrillation. And the difficulty there is that based on the usual terms in English, we would have thought that persistent and chronic were, well, persistent is a type of chronic, and chronic could also mean the long-standing persistent or permanent, or it might just mean something general, and someone might just have used that term non-specifically. So that particular aspect of it at least looks very much like it would be helpful as far as capturing more about this. Whether a case is first detected or not first detected can be of particular interest in recognizing whether it has recurred or is not recurrent. On the other hand, it's we would be proposing to use that as a secondary code in any case. And so it's basically if it's first detected and it goes away, then it's just paroxysmal, and at least we would know that. On the other hand, if it's coming back and it's more persistent or long-standing persistent, those are the types of things that are of more use. It's perhaps less clear how useful that proposed first detected code would be, since it would only be a secondary code in general anyway. If we were going to leave out one of those, I don't know, would you be suggesting we not do first detected?
Yeah, I think so, and now I've got more questions as you've been talking. Because
Sure.
then I'm thinking, if it's the first detected and persistent means it didn't terminate within 7 days, how would you know, because it's still day one? You know?
That's a good question. And you can have it be first detected and you never are able to convert it and get rid of it, and so that you you could
That raises
end
the
up
point,
having
at
it be
what
both.
point are you,
You could have it be
Docu-
permanent and yet still first detected, but that wouldn't hopefully usually be the case, but it could occur.
yeah, and at what point are you capturing that it's first detected?
Yeah.
I guess at the end of their hospital stay, but it could be in a physician's office where they haven't had it long enough to be persistent because he's just now detected it.
Yeah. Well, it would be first detected if it's recorded as such, basically, or, yeah.
Yeah, to add to Sue's comments, I mean, having gone through extensive education trying to distinguish initial versus subsequent encounter for the service characters, if you put this through, you're going to have questions. Well, first detected, how many physicians get to report that? Is it the very first physician that ever sees it? Is it the second one? Is it the same practice? Do you use it on the first day? What if they're hospitalized? Can you use it on the second day visit? I mean, I can just sort of think of lots and lots of potential problems. So I would, unless there's some clinical reason why, and it's very clearly demarcated what this first detected mean, I would recommend staying away from it.
Okay. So in any case, the way it is proposed here, it would be a secondary code in general, but I appreciate that. So we will take that into consideration. We'll invite everyone to put your comments in writing on this, and we'll see what the input we get on this is. And this is something we've looked at some before. But we'll see what the consensus is at this point in time as to where we could go with it. All right. Next. Sorry. Next, we'll look at subarachnoid hemorrhage, which is page number 67 of your handouts, and it's slide number 62. Any chance we could get you to move this up to advance it to 62 for me? Because that's a long ways ahead. It'll take me a while to get there otherwise. So that'll be nice. He will advance it for me. That is very much appreciated. I'd probably be there for 5 minutes trying to advance it, I tell you. So, and those following along in the handouts, let's look at page 67. And this is a relatively simple proposal, which is actually a bit beyond what we ordinarily do. Essentially, this is a proposal to delete some codes. So to kind of help clarify and go over this, in ICD-10 CM, category I-60 is non-traumatic subarachnoid hemorrhage. In creation of the clinical modification, we expanded a number of codes to identify laterality. One of these was for the anterior communicating artery, and it connects between the left and the right anterior cerebral arteries. While it does have both a left side and a right side, it's relatively short, and it's been suggested that the expansion to include laterality for the anterior communicating artery is not really needed. So thus it's proposed that the specific codes for it be deleted. Now, after such a change, there would still continue to be a 4-character code I-60.2 for non-traumatic subarachnoid hemorrhage from anterior communicating artery, which would correspond to a WHO ICD-10 code also. So while we would not have certain amount of the detail here, we would still have a way of identifying it as being from the anterior communicating, just not whether it was from the left side or the right side of that. As an aside, there are 2 posterior communicating arteries which go between essentially the area of the internal carotid and the posterior cerebral arteries, essentially. And so there are 2 sides with those arteries, and they're a good bit longer than the anterior communicating. So the laterality for the posterior communicating is certainly appropriate. We don't have that in front of us now. But just as an aside, we're not proposing to change that. So in any case, this proposal then, looking at the coding here, at I-60, non-traumatic subarachnoid hemorrhage, we have I-60.2, non-traumatic subarachnoid hemorrhage from anterior communicating artery. That's currently a subcategory with codes below it. It's proposed that that become a code itself, and we delete those codes that are below it, I-60.20 for non-specific subarachnoid hemorrhage from unspecified anterior communicating artery, and then also the 0.21 from right and 0.22 from left anterior communicating artery. Essentially, these might be thought to apply to the right and left sides of the anterior communicating artery, but it's a relatively short length, so it would be reasonable just to have a single code for it based on input from neurosurgeons. Certainly, I'll invite comment from Dr. Powers on this if she wants to. And she's shaking her head, not interested in commenting at this time. And we'll hope to get any other comments in writing on this. And anybody who does have comments on this, I know we usually do not propose to delete codes. And it's a bit of an awkward thing perhaps, but we did have this proposal come through. It doesn't look unreasonable from a clinical standpoint, so we're presenting it. We'll invite comments, and we'll work forward from there based on people's comments, as it were. And seeing no further comments at this point in time, we will wrap things up on that particular issue, and we will look at what other issues we can do next. I remember Pat Brooks did specifically tell me that Donna wanted to go till 5 here. But I don't even see Pat in the audience at the moment, so I'm not sure what to say. All right, I'll pass it over to Donna now.
Thank you, David. Okay, we've culled through what's left on the agenda, and the remaining items, there are about 8 items plus an addenda. We have subject matter experts that will be joining us tomorrow for the presentation. So we can't go any further. So as much as I really wanted you guys to really go to 5 o'clock, I think we'll stop now, let you catch your breath, kind of recuperate, but also it gives you an hour to actually think about some of the proposals that have been presented today and start formulating your comments to us. Yes, because we really do want your comments. And again, by November 13. This is very important because, as some of you understand, some of these have come back a second, third, fourth, and fifth time. And we really would love your comments so we can nail these down so that they can become part of the October 1, 2016 updates. Otherwise, they get to sit another whole year and be part of 2017. And I think the submitters are quite anxious to have their proposals reviewed and move forward because, again, even with the partial freeze, some of these have come back multiple times. So we really do appreciate you hanging in there today. We actually will appreciate in advance that you will be back here tomorrow for the remaining 8 proposals and the addenda. And once again, please put your comments in writing. Also, and I'll mention this tomorrow, but I know not all of you are hospital-based. In addition to the typical resources that we've had related to the ICD-10 CM that really kind of focused on the general equivalence maps and the guidelines and the files, we encourage you to visit the CDC NCHS page that is specific to public health. And the transition and how it will affect them as well. While most of us sit in here and we have real records to code from, and we've got the detail and we're prepared to go out and do the best coding we can do, please remember that some of your state departments of health and some of your other data-driven organizations that are working with codes only and don't have source documents or medical records to work from will also be impacted by the transition to the I-10 code sets. So we've created a unique page to address their concerns and to help them understand that even though they may not be HIPAA-covered entities, that they too will be impacted by this transition, particularly if a hospital is submitting things to a state data repository, and that's the data they use for multiple purposes, including surveillance and statistical purposes. So if you're interested in how others who aren't facility-based are going to be impacted and some of the toolkits and resources that have been identified for them, we encourage you to visit those pages as well. And with that, I wish everyone a good evening. And again, look forward to seeing you tomorrow at 9 o'clock. Thank you all.